Thank you so much for joining us for the first roundtable of our summer series. My name is Regina LaBelle. I'm the director of the Addiction and Public Policy Initiative at the O'Neill Institute at Georgetown University Law Center. This month and in the month of July, we will hold 4 virtual roundtables. Each roundtable is intended to build upon today's discussion, focusing on a high-level overview of the issue of medication-based treatment in correctional settings. I want to thank each of our speakers today, each of whom bring a really unique and important perspective on the issue. So I'll introduce each person in a moment, but first I want to say a few words about the purpose of our summer series. The Addiction and Public Policy Initiative at the O'Neill Institute at Georgetown Law Center is focused on using the law and policy tools to advance evidence-based efforts to improve outcomes for people with substance use disorder. And we do this by bringing together diverse voices, including people with lived experience, to promote policy solutions. So as I mentioned, today's discussion will focus on national trends related to medication-based treatment for opioid use disorder in correctional settings, and will highlight successful models and best practices from across the country. Our next roundtable, which is scheduled for June 29th, will take a deep dive into how jails in smaller communities have adopted evidence-based treatment approaches. That panel will include the Franklin County, Massachusetts Sheriff, Chris Donlin, the Franklin County Medical Director, Dr. Ruth Potey, and Brandon George with the Indiana Addiction Issues Coalition. The third roundtable will focus on research, and the last roundtable, which will take place later in July, will focus on decarceration efforts. This is an essential conversation as we emphasize racial inequality in our nation's law enforcement system, as well as the nation at large. Housing, employment, treatment services, and other social programs must be ramped up as we look at reducing recidivism and increasing diversion programs. We hope that you can join us for these discussions. So today we have a distinguished panel of, and I will, the email, if you want to register for any of our Applying the Evidence Summer Series, the URL is at the bottom. Sorry. So our first speaker is Beth Connolly, who directs Hughes Substance Use Prevention and Treatment Initiative. And Beth will provide us with a national perspective on the issue of medication-based treatment in correctional settings, but she also has worked in New Jersey's the state of New Jersey's health department for a number of years, and so can also add that important perspective. After Beth, we will hear from Warden Karen Taylor, who serves as the warden of the Camden County, New Jersey Correctional Facility. And in that position, she has advanced evidence-based treatment in her correctional institution. So we'll hear her perspective on the issue as well. Next is Michael White, who specializes in program development between community agencies and judicial systems. In Arizona, but also in other parts of the country. And then last but not least, we'll hear from Dr. Marc Stern. Dr. Stern brings an important perspective as a physician and policy expert on correctional health care. What we'll do is we'll hear from each person in turn, and then we will have a moderated discussion moderated by Shelley Weissman, who's the Associate Director of our Addiction and Public Policy Initiative at Georgetown. So thank you, and with that, I will turn this over now to Beth Connolly.
Thank you, Regina. Thank you to Regina and Shelley for putting this together and the support of the O'Neill Institute. We all really appreciate you all keeping this topic appropriately at the forefront, especially during the pandemic, and especially as we watch jails and prisons release so many people due to the virus. I'd like to lay out sort of just an overview of a framework. We have so many other great speakers who can really highlight and get much deeper into their experience in these. So for everyone watching, I'll really start with just the baseline and give a national overview. So for our baseline perspective, we know that opioid use disorder is a chronic brain disease. We also know that there are 3 FDA-approved medications to treat opioid use disorder: methadone, buprenorphine, and naltrexone. We know that coupled with counseling, that these medications and counseling are considered the gold standard of care. But medication should never be denied where counseling is unavailable. And it probably doesn't need to be said, but I will say it, that connecting people with evidence-based care reduces overdose and saves lives. So across the United States, there are relatively few correctional settings that offer even one medication for opioid use disorder. And offering all 3 is very rare. We're beginning to see an uptick in interest and in action on this front. And perhaps these are aided by the really great examples we've seen in New Jersey and in Rhode Island. And for some, maybe it's the recent lawsuits that we've seen in Massachusetts and Maine. But we're really looking forward to more increasing provision of services within the correctional setting because we recognize how important it is. We know that introducing MOUD in a correctional setting can be met with great resistance. And some states have seen great success in training top to bottom the staff in the correctional institutions. And this type of training covers everything from understanding the chronic disease itself and the treatment, its efficacy, and exactly how the treatment works. And this seems to dispel a lot of myths and a lot of concerns that folks in correctional settings may have. In addition, policymakers benefit from similar training because they can understand what the impact and the investment they make in this treatment can have to a greater community at large. For some of folks, it's easier to think of offering medications in settings such as prisons because of the long lengths of stay for people. So folks figure they have more time with folks in the correctional setting, and then it makes treatment easier to provide. However, with bail reform becoming so prominent across many states and some lengths of stay for individuals as short as 48 hours, we shouldn't dismiss these short timeframes as too difficult to manage. Strategies that are employed in emergency departments can actually act in the same way in the correctional setting. So screening, brief interventions, stabilizations, initiation of buprenorphine, and referral to community treatment have been shown to be very effective. But initiating and continuing MOUD in the correctional setting is really only half of the equation. A seamless transition to community treatment setting is really critical. In community settings, such as opioid treatment programs and primary care facilities, methadone and buprenorphine have been shown to reduce overdose deaths, illicit opioid use, and the transmission of infectious diseases such as HIV and Hep C. Discharge planning and referrals to community treatment improve post-release outcomes. Ensuring that Medicaid is suspended rather than terminated upon release is greatly improves the transition to a seamless community setting. Evidence suggests that people who are incarcerated and started on medications and counseling in the jail and prison setting are more likely to engage in post-release treatment than they did if they had not received this treatment behind the bars. There are 3 things that policymakers really need to do to support medication in correctional settings. One is to ensure that jails and prisons screen individuals for OUD and provide medications and counseling. But again, do not deny medication where counseling is not available. 2 is ensure that jails and prisons have an adequate data infrastructure to track treatment and outcomes. There are very few studies, relatively speaking, that look at treatment and outcomes for people who have been incarcerated or as they transition back to the community. So collecting this data, having wherewithal to collect the data is critically important as we all learn and increase the use of medications in correctional settings across the United States. Medicaid agencies, state substance use and mental health agencies, and other state and local entities need to work together to ensure the seamless connection to community treatment. All too often, we see that these different agencies are acting independently or siloed, and this does not help to look at the whole person and the structure as they re-enter the community. So these cross collaborations across all state agencies and with provider communities is critical to making sure that we are successful with folks who have been interacting with the criminal justice system. I'll leave it there and wait for questions for later. Thank you.
Warden Taylor.
Good afternoon, and thank you. I just wanted to take this opportunity to thank everyone for allowing us to highlight our program. We have learned through trial and sometimes error, but we want to be supportive of others who are implementing their programs, and this is a great opportunity to do so. There is a huge culture change and a huge shift in corrections, and my team and I are not alone in wanting to address substance use disorder, but there is hesitations in correctional facilities. The hesitation is due to various factors, but events such as this help us move towards that change. There's still more work to be done, but creating learning environments have helped in moving that shift. For us, is the evolution of our program, and I just wanted to highlight how we have evolved. Originally, this is not what I thought that I will be doing as a jail administrator. However, I found that this is the way that we can help our community. Our program began in June of 2018, and we started with a small grant that we received, and the grant was specifically just for medication. And we began with a naltrexone program in June of 2018. We began having meetings with our MAT committee and trying to develop policies and practices that would work within a jail setting. We were not deterred by the naysayers, and I think a lot of times we have to go beyond that and see that there is more that can be accomplished. There's always going to be someone who says you can't do this, and we have to look at best practices, the gold standard, and look at the science of addiction to ensure that we can accomplish what we were looking to accomplish. And as I said, back in June of 2018, we began with a small program of offering education and naltrexone as our medication that we were going to provide. We started with a small group of individuals that we identified are potential participants, and then quickly realized that if we work together with our community partners and other stakeholders, we could identify individuals that not only were sentenced, but individuals that were on pre-trial and offer the medication to those individuals. As soon as we were able to accomplish that, then we moved to the next step, and that was in February of 2009 to offer all 3 forms of medication. But as you notice, our evolution was critical. We needed to train our correctional staff and our medical staff on the neuroscience of addiction, because we wanted them to be well prepared to answer those questions that they were going to be presented with. Education and counseling for our incarcerated population was also critical. And at the beginning, as I said, we had a grant that would provide funding for medication, but there was no money for counseling or education for the inmate population. And in that aspect, we had to think outside the box. And we worked with our community providers to find a way that we could offer the education and the counseling in a jail setting. And that it was easily accomplished utilizing a virtual platform such as Zoom, which we're using today. So we partnered with a community partner who would Zoom in the education. And so therefore, again, thinking outside of the box, looking how to accomplish things when maybe there is no funding, but finding ways to make it happen. The implementation, as I said, there were challenges and there were some shortcomings. One of the challenges that we initially felt was the shift in the philosophy and the mindset of correctional officers, and we identified that quickly and made them part of the change, allowing them the opportunity to have a say in creating the policies, having a say in the security of the program and how we were going to address diversion. All these things were part of how we were able to accomplish to begin our program. If you haven't seen the Corey Waller video, please do so. That video allows us to be able to present to our staff the neuroscience of addiction, and they were able to really understand how addiction works. So therefore, kind of chip away at those that stigma that is associated with addiction. And so, education, support, leadership, all these things working together to accomplish what we needed to. We today are moving towards discharge planning. We are starting in MAT Care Navigators, and we'll be beginning that program soon. COVID-19 has delayed our ability to start that program, but we wanted to provide navigators to the individuals that are participating in our program. We are also starting a new program on presumptive eligibility, because we want to make sure that the individuals not only are provided with the service here in the correctional facility in the jail, but also are able to transition into the community and allow them to continue with the medication. Increased collaboration between the medical provider, custody staff, civilian workers. We created an environment where multidisciplinary collaboration was integral in making sure that we could troubleshoot and that we can grow our program. So having that opportunity, originally we met once a month. Now we're meeting bi-monthly, we met once a week, and now we're meeting bi-monthly. But having that team meeting to discuss the challenges, to troubleshoot medication, to troubleshoot bridging medication, education, all these things were opportunities of how we evolved our program. We needed to not only educate our staff and the participants, but we also found that we needed to educate also our individuals in the community, the courts, other stakeholders of the criminal justice system. So we will go out and educate, do a PowerPoint presentation on how the program works, what type of medications are available. And so this allowed us the opportunity to have partnerships in the community. Group therapy sessions, individual therapy sessions, all these are part of our evolution program of how we move forward with our program. And so we ask the questions, what are our program outcomes? Are we having an impact? And is that impact a positive impact or a negative impact? Is our program successful? And what defines success? All these are the questions we are constantly asking ourselves. Are there any unintended consequences of us starting a program, and what are the related policies and practices that we need to evaluate? So these are the questions that we are constantly asking ourselves as we grow our program. And how do we measure impact? I think Beth spoke about data that's necessary. I wanted to know is when our individuals are leaving our facility, are individuals overdosing upon leaving the jail? What is the success rate of treatment post-release, 30, 60, 90 days out? These are measuring data that is so important for us to be able to understand, is our program working? Rearrest, reincarceration rates, suicide attempts, are they decreasing because individuals are placed on medication? Negative interactions, use of force, inmate assaults, are those decreasing? Inmate on correctional staff assaults, are they decreasing? All these are measures that help us when we are looking at our MAT program. And we all have our opinion and our thoughts about what impacts, but we have to have data. And you're going to see that we are now screening. We need to know how many individuals are coming in, how many individuals are screened, the percentage of individuals that are assessed. We're looking at the individuals that started our program, the percentage of individuals that are compliant with our medication and treatment program, whether the percentage of individuals that are continuing with a provider in the community, and when they're released from our jail. The number of bookings, fights, individuals there are potential suicides, has suicide decreased within the correctional facility. And so these are program impacts that we are measuring through our MAT. But we always say that we have to utilize the data to tell the story. And so as you see, at the beginning, we were looking at Vivitrol and how many of those individuals on Vivitrol were also in our reentry program. What is the length of stay on individuals on Suboxone, 24 hours or less? Beth spoke about New Jersey specifically with criminal justice reform and bail, doing away with bail. Today, we're looking at individuals that live our facility within 24 to 48 hours. So we needed to know what is the length of stay of individuals on a particular medicine. And so we have the data that tells us that. How many of those individuals are what type of medication, whether Suboxone, naltrexone. And so we're looking at data to tell us and help us to tell our story. As you see, we've developed this is a snapshot of May 27th in 2020, our dashboard, which allows us to know on a daily basis how many individuals are on MAT, how many days there are on MAT, what is the demographics of the individuals that are on our program. All this will help different departments understand how to utilize this data to then take it to the stakeholders and say, my program is working, because I know that individuals are leaving the facility and being linked with individuals in the community to continue their programs. And so this is a quick snapshot that I can utilize on a daily basis to be able to determine how many individuals our clients are also on the different types of medication. I'm here to assist in any way. My number will be provided later on. If you need or have any questions, please reach out. At the beginning, when we started this in 2018, there was not that many individuals or correctional facilities that I could call on to assist us. But today, I'm here to tell you that I'm available. And if you have questions, whether it's the physical plant, whether it's the security diversion, I'm here to help in order to get your plan started. But the main point that you need to take today is get your program started. Start small, but start. Thank you.
All right. Morning. Mic check. Everybody can hear me? All right. My name is Michael White. I'm with a company called Community Medical Services, and we tend to provide medication-assisted treatment to a few different facilities, about 24 as of right now. Ms. Taylor mentioned the employee culture. So when implementing programs like this, you'll run into a couple situations that might deter you from accomplishing the goal. Employee culture, Ms. Taylor kind of hit on that. She has a real good strategy of getting that buy-in from staff. I love having them involved in the policy and procedure part. Correctional and community leadership, not aligned. So you might have the sheriff that's against it, but the third-party healthcare provider does want to implement it, or vice versa. Or maybe politically, it's not a very good topic to discuss in your community at this point. So maybe politics is playing a part, but there's just not alignment between the systems that have to get it started. Pharmaceutical companies can come in and get people focused on a certain direction that might not make sense to their available resources or what they have available in their community to hand people off to. So that's another part that can be confusing. Third-party healthcare providers, so contracts. So you'll see these bigger jail systems. They'll have a third-party healthcare provider like NAFCare or Centurion or Health Partners or some of these other folks. And maybe it's not in their existing contract to provide MAT, so they have to renegotiate a contract or they have to do some other certain things within that. So that can be a deterrent that needs to be looked at. The number one concern is always diversion, mismanagement of medication or having offenders get a hold of medication that's not theirs. There are certain protocols that can be put in place, separate med lines, more constricting med lines and other things of that nature. And then just facility and staff resources. So some systems I work in have a daily population of 75 to 8,000 people. Other systems might have 5, like Minot, North Dakota. And so you have these rural places, and they might just not have medical services available to them, or their medical staff's moonlighting, where they're just on call, or they come in 5 hours a week to check in with people or sign paperwork. So you'll see those things too. And then just flat out overwhelmed at the idea. Starting from scratch can be very overwhelming, and just where do you start? Where's step one? So all those things can play a part. These are some of the facilities and areas we support. So you can see some very big jail systems or prison systems, such as Arizona, and you can see some pretty small systems, such as Minot, North Dakota, or some other locations in Montana or Alaska. And so there's a couple different ways to support institutions with MAT. You kind of have a bridge model, which if the third-party healthcare provider is actually doing the prescribing and the providing of medication. So in this case, one of our partnerships, NAFCare doctors, are actually providing the buprenorphine products, but they just need that warm handoff to the community to make sure that people aren't missing their medication once released. So really it's our peer support going in there and then coordinating that reentry services to a community provider, whether it's us or somebody else. It's usually to the closest, wherever they live, wherever they reside. We're trying to get them to the MAT provider closest to their house. Co-location model, probably the best example of this is Rhode Island and Kodak with their relationship, where Kodak's actually within that DOC system, and they're providing the counseling and the MAT and all of those things, which is a really interesting and neat model. And we're lucky to have them as a example. A delivery model, in my experience, is the model that's used the most. A lot of times correctional health individuals or systems just aren't ready to hold on to this medication for whatever reason. And so they really want that community provider to bring in the medication and to provide those OTP services on behalf of the jail. And then a daily transport model. This actually means bringing the offender into the clinic every day. And those, the money associated with that, it could be a daily transport fee of $850 to thousands of dollars to do that double guard daily transport to bring somebody into that clinic every day. And then in the future, we do, because of the deregulation in COVID and those other things, we do have the ability to do telehealth models in some aspects right now. And so in the future, could we look at that to even help rural jails more? And I do think that's probably a very important topic. Maricopa County Jail, I wanted to hit on just because there is another model where it's an independently licensed OTP model. NAFCare, which is a third-party healthcare provider, is actually looking at doing a lot of this too in some of their systems, Reno and Cleveland to be specific. And so they're looking at individually getting a license. So in Maricopa County, 5 jails are independently licensed OTP. So what's funny is if you go on the SAMHSA treatment locator, Maricopa County Jail actually shows up as a treatment provider. And so anybody that goes into this jail, they're provided maintenance. They can also be provided induction and other things of that nature. North Dakota, what's interesting, Cass County, you see these, in my opinion, small rural jails. So you can see that we served 37 people over the year in Cass County, Ward County, Minot, 38. And then I always just give a shout out to North Dakota Department of Corrections and Rehabilitation. They are providing MAT for up to 36 months for their people incarcerated because they know that they'll capture 95% of their opiate use history population within that 36 months. So they're really doing it to the standard I believe should be set. Another smaller kind of relationship we have is with Alaska Department of Corrections. So we supported 30 people in 2018, I believe. It's gotten a little higher because we're starting to support their MATSU pretrial services, which are people not adjudicated for their potential or their potential crime. However, I'm trying to say that right. And so we've been working with them, and this is a delivery model, so our nurses are driving there daily to provide that medication. I just wanted to point out that in Cincinnati, Ohio, we have a project where the third-party healthcare provider is actually providing all the medication services, but we have a peer support that's going in and engaging that person throughout the entire stay of their incarceration. and we're really trying to develop better reentry warm handoffs and that nature. So we're really trying to get together a collective impact, and we're at the beginning of phases of that project. So more information to come on that. And so any program I do with MAT, I need to have people go in because we need to engage those people. We need them to follow up with the community treatment and those things. And so I do not have any projects that I do not have peer support going in and meeting with the offender too. I don't think it makes sense not to have that piece. And so when we're conducting in-reach, we might be working with the jail to start an induction. Maybe somebody said, hey, I have an opiate history. I would really like to start MAT. At that point, we can help them navigate the requests of induction. We start that engagement. We start that relationship. We have the opportunity to combine efforts with jail staff and then reassess the plan based on our peer supports information, because oftentimes they get better and more detailed information. It's the ability to hold the participant accountable too. Oftentimes we're working with the drug court in the area, and so their accountability measure is 24 hours in jail for each thing they didn't accomplish within their contract. So this makes it so when a drug court client goes to jail, they're not missing out on their medication, which is very important. Then there's a sense of reach out, which means the jail staff is looking for a resource from the community. So they're asking the community for support. And then where reach-in services are people going into the jail and setting up those resources on behalf of the jail for community release. And then we can also coordinate care to the DOC to make it easier on staff when accepting those individuals on MAT, and possibly they have to titrate off those medications. This is an example of our outreach guide, basically, or our in-reach guide. This is all the services we want our peer supports to have access to so we can make warm handoffs to these connections. And then we did a study from 2015 to 2019. I just want to point out the sample size is 266. And this was done in Arizona where 266 people not previously on medication-assisted treatment and did not qualify for Medicaid because they fell through the gap because of funding or some of these other things. They were provided medication-assisted treatment in jail and upon release. So now we're going to look at the outcomes from those people. What we saw was a 36% reduction in arrests, a 43% reduction in drug arrests. In regarding to social determinants of health, and we know that those often play a major role in accomplishing goals or just being successful, a 28% reduction in unemployment and a 71% increase in employment. And we also saw a 39% increase in permanent housing. So we saw some great things come out of that. What I do want to talk, and what I hope we talk about more today, is what would help these collaborations, because really we're lucky where it's a synergistic response to our problem. So our solution really helps everybody involved. It helps the client, it helps the community provider, it helps the jail get around lawsuits, and it just provides appropriate healthcare, in my opinion. And so some of these things I hope we get into today. But just expansion of telehealth, Medicaid possibly opening 30 days pre-release so you can encourage community providers to come in, and that would be a good carrot, in my opinion. Medication units, naloxone. Everybody should have naloxone in their hand once released from jail or a prison, in my opinion. Counseling services. Can we implement tablets? Can we provide curriculum on tablets and other technological platforms? Medication efficacy, what's the best return on investment for the medication we're using? And then partnerships, just that being able to have a connection to a legal liaison or a legal advocate or the VA or just whatever your clients might experience upon their release. And then co-locations such as Rhode Island and Kodak. And then I just wanted to provide some resources, because I know these slides are going to come out to you. The National Council just put together a real good guide, and then NCCHC put one out about a year before that. But these are fantastic, fantastic resources if you want them. And that's all my time, so thank you.
Great, and I think that leads to me as the caboose. Welcome. So I'm going to spend a few minutes recapping, reminding us why we're talking about providing opiate treatment in the jail setting, do an outline of some of the key components of a jail treatment system, and highlight some of the challenges and opportunities. And this is going to tie together some of the things that we've already talked about. So why are we spending time talking about this in jails? And there's a number of reasons, but I'm going to touch on three. First of all, it's a perfect time, unfortunately, in the sense that people are often hitting bottom when they're incarcerated for drug-related problem or drugs were involved at all. Secondly, after a few days, they're drug-free and maybe the first time that they can make decisions with a clear mind. And third, I love to say that they're captive audience in terms of education and treatment. So this may be a perfect moment for us to treat them. The second reason that we do this is based on something that we learned in medical school called Sutton's Law. When Willie Sutton was asked, why does he rob banks? He said, well, that's because that's where the money is. Dr. Cindy Grandy in Olympia, Washington, did a study about a year and a half ago here in Washington looking at opiate treatment in the jails. And the study showed that very approximately there are about 47,000 opiate addicted people in the state of Washington. But what's really interesting is that over half of them were coming through the doors of one of the Washington jails during a year. So that's where the money is. That's where, unfortunately, we are the epicenter of opiate use disorder. And so if you want to get more than half the people, have your hands on them, touch them during a period of a year, that's going to be in a jail. And then for the third reason, I'm going to call on James Whitmore. Those of you who saw the Shawshank Redemption may remember the scene of Brooks, the librarian, coming out of the prison after years and years of being incarcerated. And in the next scene, we see Brooks killing himself. Dr. Ingrid Binswanger, one of the great researchers in corrections and in substance abuse, did a great study back in 2007 that was in the New England Journal. Many of you are familiar with it, looking at mortality upon release from incarceration. And what you see here is this is the mortality rate while people are incarcerated compared to their mortality rate in the community. So it's actually, mortality-wise, a little bit safer to be incarcerated. But what's really noteworthy here is that in the first 2 weeks after release from incarceration, the mortality rate skyrockets to almost 13 times what it was, what it is in the community. It eventually comes down somewhat, but it still remains very, very elevated. So at least three reasons why we're spending time talking about this topic in jails. So let me transition to the next piece, which is what does the system for opiate treatment look like in a jail setting? And I'm going to pull together some of the things that we've already heard this morning, actually this afternoon for those of you who are not on the West Coast. So here are four different types of people who will be coming into a jail with opiates of some type. The pregnant woman who's on opiates, the person who is on MOUD, medication for opiate use disorder, but that has been prescribed by an MD. People who are on opiate also prescribed by an MD for pain. Now these are not, this third group are not opiate use disorder patients, but I lump them in here because they get lumped in many jails with the rest of these folks. And then third, the biggest group are those who are on opiates on the street. They're not prescribed by a physician. So what are we currently doing with those people in a lot of jails? Well, pregnant women, fortunately, most jails recognize the need to continue opiate treatment as they come into jail, while they're in jail, and when they get out of jail. For the other three groups, unfortunately, we still have some jails who treat patients on those three regimens with cold turkey, or WD for withdrawal. So what should the system look like? Well, first of all, pregnant women, we want to continue to keep them on their opiates. The people who are on MOUD on the street should continue that without interruption through the jail admission and until they get out. The patients who are on opiates for pain under prescription also, assuming that that prescription is appropriate, assuming the physician agrees that it's necessary, that there's justification for it, the medical record supports it, that should continue also. Our biggest worry are these folks who are on a street opiate, and better than doing just withdrawal by cold turkey. And by the way, I want to say parenthetically here that many of us learned years ago that withdrawal from opiates is not a fatal problem, a fatal condition, that it's very painful and annoying, but it doesn't kill you. That's wrong. Those of us who work in corrections know that people die from opiate withdrawal. And it's not just 65-year-olds with heart disease, it's 25 and 30-year-olds who are otherwise perfectly healthy. So this withdrawal from opiates is a potentially fatal problem. So one approach, and I put this in parentheses because it may not be the best approach, but it is one that's an improvement, which is to use buprenorphine as a taper to take people off of their street opiates. That anecdotally, at least, even jail administrators find that this is less wear and tear, not only on the patients, but also on the staff. And then after when they're getting ready to leave the jail, having a warm handoff to an MOUD provider on the outside is one option, or sometime before they're leaving the jail to begin them on an MOUD, and then again transition to an MOUD provider on the outside. But perhaps the best approach, and one that that some places are starting to do, is to, if the patient is interested in doing it, is just continuing an opiate without a gap, transitioning from what they're on to an MOUD, and then continuing that into the hands of a community provider. And I just put a small exception here for naltrexone. We have to deal with it a little bit differently because there needs to be a gap between their opiate and when you start the naltrexone. Hopefully counseling is part of the program in the jail. It is not an absolute necessity. Some patients, one of the reasons we migrated from the term MAT to MOUD was to emphasize the point that even if you can't provide counseling, medication by itself provides value. And the last piece of the model, as Michael mentioned, is providing naloxone upon exit, either to the patient, to their family, or to both. So let me wrap up with some things to talk about that are, like I say, challenges or opportunities. What MOUD to use? Methadone, buprenorphine, naltrexone. Well, in some communities, smaller communities especially, you may not have access to a methadone provider. That's a problem for us in a number of communities. Michael presented some options for addressing that. There is the most research about methadone, less about buprenorphine, and the least about naltrexone. One of the things that's frustrating are facilities who have responded to pushes from pharmaceutical companies and provide only naltrexone. What is the best medication to use? And actually the best one to use is the one the patient is willing to use and the one they're willing to take. So all programs should have availability of all three. Again, sometimes we can't use methadone because it's not available. The second point I want to make is that, as again Michael pointed out, some places partner with an outside MOUD provider who comes into the house and provides treatment there. My caution there is make sure that care is coordinated. If you have a bifurcated system where a doctor takes care of one part of the patient and another doctor takes care of another part of the patient, the patient can fall into cracks. In other words, for example, a patient has vomiting. Well, is that because they're not getting enough MOUD or because they have an upset stomach from another cause? which doctor do you call in? Those kinds of coordination pieces can be dangerous, so keep that in mind. The third thing to think about is the patient who is not transitioning to the community, but transitioning to either a prison system or ICE, and those present special challenges. Hopefully, prison systems will start to have more and more of MOUD available so that the patients just transition on the medication, but that can be a challenge. And the last two things I'll mention, again, Michael touched on the third-party for-profit healthcare providers, and who provide care probably in more than half of our jails. And the leverage into that change is the RFP, or request for proposals, and contract. That's how you make that change. You incorporate the requirements for MOUD and its measurement in the contract that you have. And the last piece I'll mention, and maybe even the most important person in the institution besides the patient, I think, sometimes is the correctional officer and correctional staff. As Karen pointed out, they are important. They can make the system and they can break the system. One of the things that we've started to do here in Washington, just before coronavirus, in our academy for jail, training academy for jail staff for the state jail system, we introduced the first program for training them and teaching them about MOUD, about opiate addiction. And it was just really heartwarming and wonderful to see the excitement and level of understanding of the officers. They can really help make the system work well. And I will stop there.
Thank you very much, everyone. Great information provided. A couple of we will have these materials. We're going to caption this recording, and then we'll post it to our account later, and we'll let you know when. So I'm going to turn this over now to Shelley Weissman, who will lead off with a few questions, and then we'll get to some of your questions in the Q&A box. We have lots of participants, and we go for another 45 minutes. So if you have additional questions, please feel free. Thanks, Shelley.
Great, thanks, Regina, and thank you everybody so much. That was a great overview and getting into some details. I'm going to start off with a couple questions and also get to questions that have been asked in the Q&A box. So I encourage participants, if you have questions, put them in there into the box on the screen marked Q&A. So, you know, a number of you kind of got into details about what your programs look like and how to implement. And, you know, Mike, you touched a lot on, you know, the brain dump, right, of kind of ideas for innovation for the future. And, you know, obviously we are in a pretty incredible time right now, all across the board in society, where we've had to, you know, take a look at how public health systems respond to crises. There, you know, is obviously a real kind of looking hard at the deep-rooted systemic inequality in many of our systems, and a shift in even in the addiction and recovery community around, you know, moving towards embracing evidence-based treatment. And I'm wondering, you know, what do you see for the future of the treatment and recovery system, and how do you see the work of that's going on, you know, in these jails and prisons that's innovative connected to that?
To me, like the first question when I meet with a jail, it's always around resources. And so that's like initially number one, like what do you have available to work with, and how stressed out is your system? Because if it's real stressed out, we're never going to get it off the ground anyway. So how can I take work off the plate of that staff and kind of take it onto my staff to make your job easier and to just make it flow better, right? And so I think some of the things that are coming out of COVID is that telehealth. And so I think the ability to have a computer set up in some remote jail in upstate New York that has a population of whatever, if that offender can sit in front of a computer and have access to treatment, I mean, not only for jails, but just as a country in general, our biggest struggle over the 5 years is how to figure out access to care. And so OTPs, historically, they're open 4:30 in the morning to 11:30. It's not very supportive to certain lifestyles. You know, you kind of got one shot to get in there and get your meds for methadone specifically. And so those types of things need to be figured out and adapted to the crisis. The crisis can't fit into the structure. You know, our structure is wrong, so we got to change the structure. So I really do think telehealth, and I like the idea of tablets because I'm a big fan of education. Medication by itself can work, but I still believe, you know, research, but I'm not going to get into that debate. My personal philosophy is counseling helps. And so when we have that captive audience, can we implement tablets? Can we implement other technological platforms to give those people education, resources, information, and basically turn them into their best advocate? Because we don't, it's like the whole thing, we don't want to fish for somebody, we want them to teach them how to fish for themselves. And we really need to educate and empower, basically.
So Beth, you talked about this kind of need for agencies that might be in, you know, complete silos to work together, to collaborate, and you know, what are some opportunities there, especially given the time that we're in? We know that COVID-19 has really kind of come in and for lack of a better word, you know, really decimated state budgets, local budgets. You know, where are there efficiencies that can be built into the system, and what are we seeing now that we can build on towards a, you know, better system?
Thanks, Shelley. A couple of things. One is taking a look at your expenditures. There's a lot of federal money coming down for COVID, and how can we use these federal expenditures in a way that offsets maybe other state expenditures, thereby freeing up the state funding to bring it to the correctional institutions. We know that the federal government does not permit Medicaid to be used inside the jails and prisons. Some states have asked for that through the waiver process and are awaiting some federal response. That would be extremely helpful to prisons and jails. But really, and this is where it comes to the collaboration, is sitting down with your partners and looking at how the states are spending this federal money that's coming down, and directing some of the one-time use money to the new money that's coming down, and then that by freeing up some state funding to actually that will be recurring in the jails and the prisons. Also, in terms of some of the federal regulations that have been relaxed during the COVID pandemic, if some of these were to continue, especially in the area of telehealth, this could actually be a cost savings to some of the institutions, and that thereby, again, freeing up more money to apply. The telehealth relaxation has been really important in this time during the pandemic. The idea that it might be rolled back once the public health emergency is ended is troubling, because the telehealth relaxations have really allowed jails and other spaces to bring telehealth into that space, and it's been so important. Another piece, not just the counseling piece for telehealth, but the prescribing of buprenorphine. Prior to the declaration and the federal relaxations, in order to receive buprenorphine, you had to have face-to-face contact with the provider. And through telehealth, you can now do that virtually, which really is a way to increase access to people behind incarcerated, because they don't have to have someone there in the facility to actually do this face-to-face contact. So these regulations can really go a long way to help states both financially and then to increase the opportunities of treatment if they are to become permanent.
There Warden Taylor, you spoke about this kind of really robust outcomes measurement and data collection. And I'm wondering, from your perspective, you know, what are kind of some of the key things or additional things that can be done to prevent people with substance use disorder from becoming incarcerated in the first place? How can we kind of shift the, yes, right now, and I think this is also a good question for Dr. Stern, people who are currently incarcerated, it's a group of people that's there, and it's a prime kind of time for treatment intervention. But what more can we do to kind of prevent that situation from happening in the first place?
Thank you. I think the doctor spoke about having a robust link to the community. And so what we've decided to do is not only provide medication in the facility, but wrap it around the services that we have in the community. Because I could have an amazing program here in the correctional facility, but if it is not continued in the community, we're just setting up the individual for failure. And so wrapping around the services, the warm handoff, the doctor spoke about that. We are in the process of creating a bag where we will put in Narcan in the bag, where we will put in harm reduction fentanyl strips in the bag. Because the reality is, I cannot help someone if they have overdosed and died. But if I can reduce the chances of that individual fatally overdosing, it gives me another opportunity to get that individual into treatment. So I think reentry services have to be hand in hand with your MAT program. You cannot just medicate our way out of this. We have to provide services in the community. The majority of the individuals that come into the jail setting are going right back to the community within the next 30. In our facility, our length of stay is 22 days currently, even with COVID. So those individuals are going right back into the community, creating partnerships so that individuals are treated in the correctional setting and then transition back into the community. I think it's going to be the best way for us to assist and ensure that the services are provided. That's why we're looking at eligibility for Medicaid. That's why we're looking at the ACA. That's why we're looking at just providing services, not only here in the community, but here in the jail, but making sure that our peer navigators are working with those individuals in the community, helping them to be successful. Housing is huge. Homelessness I cannot medicate someone when the first thing that they're thinking about when they leave is, where am I going to live? And so therefore, creating in the facility those programs that will allow to transition that individual into safe housing, whether it's with family or whether it's at a hotel that we are paying for through our grant funding. We have to get creative about how we're going to assist the individuals. We have to provide that warm handoff. More of a hot handoff, I believe, not a warm handoff, where that individual is met at our door in the upon release and is taken to our system providers. And if we can do that, the individual will not return to your facility. And isn't that what we eventually want to do? Reduce the number of times that individuals come into the facility and that they're successful in doing so. And then they can come back and be your peer navigators, because later on they will work through the system. And we found that individuals coming back and giving back to the program has been very successful, not only in helping, but also their own sobriety.
Shelley, I'd like to go back to the money question you asked a little bit earlier. I am very afraid of what's going to happen to every program in the post-COVID era. Everything is going to suffer. So what are the strategies? There is very, very good evidence that opiate use treatment, that drug treatment is cost saving. There are very few things in healthcare that are cost saving. There are things that are cost effective, but things that are actually, you get return on your investment. There are very few, and drug treatment is one of them. I think it's incumbent on people who operate jails to know that. And use that information. The points that Beth and Karen brought up about data collection is terribly important, so that you can demonstrate when you go to your county commissioners that the drug treatment that you've done so far has saved money, to make the argument for getting additional resources. And the other useful way of getting resources is the storytelling. I encourage jails to remember the person, that individual, even though it's not a lot of data, it's a very compelling piece of information. When you have one person who's, let's say, been in and out of the revolving door of the jail for the last 2, 3, 4 years, and you implement your program and you don't see them again for a year, and they have a job and they haven't come back, and you grab that person, and if they're willing, you bring them to the county commissioner meeting and have them tell their story. It can be a really powerful way of getting additional funding and showing how the work that you've been doing does pay back not only to the jail but to the community.
So I'm going to start with some of the questions that are coming in the Q&A box. I think one kind of theme is, you know, Mike, you talked about different models, and Dr. Stern, you talked about, you know, what the protocol should look like, and these different tools for contracting with correctional health vendors. Warden Taylor, you spoke about, you know, just get it started. And some of the questions coming in are, well, how do we pay for it? You know, how do we pay for this? What are kind of the mechanisms?
150, Sergeant Aroliga, 150.
For you know, getting this off the ground. So maybe we'll start with Warden Taylor. You know, where does the money come from in your program? And then maybe we'll kick it to Mike about, you know, what do you see around the country from your perspective? You know, you guys work in large jails and also kind of small rural jails, and what works, and in particular, paying for things like peer supports.
Well, in New Jersey, we were very, what helped us get started was that there was a push. The opiate epidemic was hitting our communities very hard. And so the state, through the DOC program, received federal funding. So that's how we started. And then actively, we started looking at our own funding through applying through grants. And so the COSAC grant, and we've looked at other ways to just fund, but the main thing is the medication, and that's very expensive. So we are now writing and preparing for our next RFP to solicit a medical vendor, and we're incorporating into our contract for the next contract that will be issued and awarded to our medical provider to incorporate MOUD. And so we are now looking forward to the next 3-5 years, depending on how long the contract is, to be able to provide that through our medical provider. So grant funding. Also, as a jail administrator, you have to look at what you currently have, the resources that you have, and where you can shift those resources. I could tell you at the beginning when we were doing the Butte distribution and dispensing, everyone was asking me, well, where are we going to find those officers to provide the security and the diversion? Well, I started looking at how many individuals do not start, well, we start, let's say, at 7 o'clock in the morning, but really don't start their true work till about 10. And identifying those individuals, and those are the individuals that are used. And I said, instead of going and get a cup of coffee and walk around the facility until 10 o'clock, we diverted those resources to our MAT program. And so it's just trying to be creative, trying to understand that sustain your program, you have to find ways to speak with those commissioners that hold the budget and the purses. And as Shelley said, and Dr. Stern was saying during this presentation, is that the data, when you tell that story, when the individual comes in, and you have to utilize the media. A lot of times there's pure correctional facilities, no one knows what's happening behind the wall. Well, create a positive media outreach and bring the media into your facility. We did that in Camden to show them that this individual was in our program. And here we are 8-9 months later, the individual is doing so well. And the individual was provided the platform to speak. And Dr. Stern specifically said this, allow them to tell your story, but then also utilize the data. And I think that that's how you're going to get additional funding, because when people see that it's working and it's costing a lot less than having individuals incarcerated, the money's going to start flowing. And I think that's one of the things. When I look at how I'm going to do this program, the main thing I wanted to make sure is that I can sustain it. And that's having the opportunity to tell our story based on the data that we found. And we tell our story. We don't allow other people to tell our story, but we tell our own story. And that might mean getting outside of that comfort box and getting in front of a media and saying, listen, this is working. And this was working in a correctional setting. And the reason it's working is because as soon as people walk in through our admissions area, our booking area, the first question during the medical intake that we ask is, do you have an opiate addiction? Do you have a MOUD? And how can we help? I'm sorry, SUD. And how can we help and get the individuals to buy into your program? And at the beginning, people didn't want to be part of the program because they also have that same stigma. They don't want to be associated as addicts. And so we had to find ways to use our jail management system, ways to find that it's okay. And when they realized that it was a safe space, now people tell us, I have an addiction, I have an opiate addiction, and I need help, and how can I get help? And we're able to transition them seamlessly into the program. And now they trust us, and we bought into their trust, and they're able to say, yes, I want to participate. And they actively are seeking the help when they come into the facility, where in the past, individuals didn't even want to let us know that they had a problem and that they needed help.
Mm-hmm. So Mike, I'm wondering if you can talk about some of the payment models that you've seen be successful, and also, you know, with a focus on peers and how does that get paid? And then we also had some questions about, you know, what about peers who have a felony and they're, you know,
so if I don't hit on that, remind me, because I do want to hit on that one. So number one's grants. And in my experience, so I've had a couple different organizations grants. BJA's grants have been completely easy to work with, just to throw that out there, and they've been coming out with a lot of opportunity lately, so keep your eyes out. If you're not on the newsletter, they'll send you out announcements, so get on that. So grants is the one. Another one is fractions of time that we always talk about. So if you get a collective impact team together, instead of having one agency staff putting up 100% of their full-time employment status to conduct that program, maybe you have 5 different agencies that all donate 10 to 20% of one staff's time, so it's not taken out of one entire agency. So we've seen that be productive, especially in Maricopa County, where they let several different community providers in. So my staff doesn't necessarily have to go in there every day anymore. So that's been helpful. Maricopa County also goes through their county budget. So they're actually funded through their county budget, which is another way to do it, because they do see the return on investment, and they have been able to demonstrate that. So they see that as a need. Donations, so Ms. Taylor mentioned it, but pharmaceutical companies oftentimes will provide donated meds because they can be expensive. So you can look at things like that, especially with naloxone and naltrexone. And then I believe with Sublocade and other injectable buprenorphine products, you might be able to talk to those pharmaceutical companies as they come out to market too. And then another one from a private clinic perspective, you know, all of our marketing dollars in theory is to get referrals, right? It's to have a customer base. And so one of the little things associated with this is, what if as a clinic, I took out my marketing dollars and actually hired peer support? And so instead of having marketing, my marketing dollars are just hiring peer support to provide community support, when it's in itself is a type of marketing, but it's also providing appropriate care to the entire community, and just it's better. And so that's been one thing that we as a company looked at and did do that. So we actually took money out of marketing dollars and provided, our hope is that each kind of region that we have these projects and programs that we would have a peer support dedicated to those folks that go through those areas. And so that's another way to fund or to think about funding.
And then what about the felony issue?
Oh yeah. So that's been a pain. In my perspective, I want people with the longest rap sheet possible. In my experience, those have been the best people I could possibly hire, hands down. They often have volunteered for stuff over years, and I find them through system partners and everything. But yeah, when you put them in for the badge work, they do not want all those pages of background information, and they get a little hesitant. And so we do run into issues if people have been in that facility in their past, so they might know people in there. But really, as the relationship develops and trust increases, and you all kind of get on the same page, that tends to go away, and you can find kind of compromises where you'll be able to get people badged in. But it still is an issue. A lot of people set up kind of guidelines, so you have to be off paper for a year, let's say, and just for everybody on the call, being off paper, off probation or parole. And so that might be a distinction that you have to do, or you couldn't have been in the facility in the last year or two, or you couldn't have an interaction with police in the last year. So there are some guidelines set up, so you kind of know who you can hire, but then sometimes they don't get approved and you've hired somebody that you can't kind of use for that specific project. So it does turn into an issue.
Maybe telehealth can help solve that issue.
Yeah, so we're actually using that, and that's a good point. So in Maricopa County, we have this phenomenal pregnancy peer. I mean, just hands down great. But we can't get her approved because there were some things. And so we couldn't get her in, so we moved her to telehealth. So she's doing her pregnancy in-reach via telehealth right now, and COVID kind of got us to come up with that solution. So, and now we're going to move it into Arizona DOC. We're on emails this morning to try to set up the same thing in fear of another spike in fall or this summer. So
that's great. Kind of pivoting, a question for Beth, and then of course if others have insight. Certainly smaller jails or rural jails have really differing access to resources than some jails in larger cities or where there's, a lot of methadone available, for example. And I know Pew's done some work in Louisiana, which has more rural areas, and that you've seen some other things from around the country. And how do you think the needs of people who are living in rural areas can really be met when there might be some of these additional challenges and barriers and scarce resources in these areas?
Thanks. So a few things that can be very helpful in rural areas, not just in a correctional setting, but also in rural areas in general. In terms of methadone, so setting up medication sites, which are satellite sites for OTPs, that can be very useful. You can have your satellite site be the jail or the prison. You could also have it be, part of an FQHC or some other place where folks are getting, their other healthcare treatment, and that can be very effective. The DEA right now has a moratorium on mobile methadone. And so unfortunately, some states, including New Jersey, have actually used the mobile methadone van to go to the Atlantic County Jail and administer not only methadone, but buprenorphine to folks at that jail. Now, New Jersey is lucky because they have, I think, 5 vans. So they really have the opportunity. The DEA recently released regulations and asked for comments. So we urge the DEA to act quickly and swiftly because mobile methadone and mobile vans in general could be very useful in settings such as correctional settings in rural areas. Increasing buprenorphine prescribing, there's a lot of work that has to be done on behalf of the practitioner in order to become waivered. However, if waivered, then they offer another opportunity in a local area where a general practitioner or a physician's assistant, a nurse practitioner can be the prescriber of buprenorphine. There's a bill in Congress, the Mainstreaming Addiction Treatment Act, which would actually eliminate the waiver, the X waiver as it's called, to allow all physicians to prescribe this life-saving medication. And so that is another way by enabling more people to prescribe to get this medication, this really important medication in a lot of areas.
So, Dr. Stern, I don't know if you wanted to, add anything to that. And also, while we have you, certainly opioids and heroin are not the only drug that people use, and it's not the only challenge that we see in corrections. And I know that in particular on the West Coast and now in other areas of the country, there's been a resurgence of the use of meth and other stimulants, and obviously benzodiazepines is a big challenge. Sometimes people come into the jail on very high levels of benzodiazepines. And so, I'm hoping you can also touch on what is kind of best clinical practice and process for addressing these other substance use disorders or polysubstance use.
So thank you. I'll follow up on Beth's answer and reinforce two things there. First of all, I think telemedicine, as we've all been talking about, is a wonderful tool. It incenses me that the federal government puts restrictions on telemedicine and puts restrictions on prescribing and or availability of methadone and buprenorphine, but has no restrictions on who can prescribe opiates. So we can get people addicted, but we have special rules for how we can get them unaddicted. I guess it's just the wisdom of Congress, but we need to do what we can at a policy level to make sure that we don't slide backwards with telemedicine rules, and that we move forward with the kinds of rules that rule changes that Beth's talked about with regard to methadone and buprenorphine. It's just logical. With regard to the other two substances, I first want to mention that benzodiazepines are also potentially fatal drugs when withdrawn improperly, just like opiates. I think there's a little bit more recognition of that, has been for years, just like alcohol withdrawal, which is another drug on the list. Alcohol and benzodiazepine, most people know that can be fatal, but I continue to see deaths around the country in jails from improper withdrawal from benzos. And as happens often, people are on more than one drug, and so a patient will come in on opiates and on benzos, and the opiate will be recognized as the drug that they're on, but the fact that they're withdrawing from benzos is not appreciated as much, and they end up dying. Unfortunately, we don't have specific drugs for the treatment of benzos long-term and for methamphetamine. However, counseling component remains important and is valuable. So yes, we are seeing a resurgence, and we need to not forget about those drugs, especially methamphetamine. I'm glad that you brought it up. And we need to continue to provide at least counseling treatment.
So we got some questions in, and I'll direct the kind of a couple of them to you, Warden, Taylor, and if others have insight, please feel free. So we got some questions about, specifically around addressing diversion and what has been effective, and what's the kind of right approach or philosophy to take with it. And then also questions related to engaging with probation and parole. So, as you've talked about, you can do everything, to get people access to treatment while they're incarcerated, but what about after? And what are some, strategies that you've seen be useful there?
Yes, diversion is always huge in correctional settings, and that word keeps coming up. But what I found is that through a robust training program of our staff, changing the philosophy, understanding addiction, allow them to, originally, when we first started the program, the individuals are going to, I explained to my staff that when the brain is damaged, you're going to make wrong decisions. And so therefore, we had to take that into consideration, that the person is not well, and that the frontal lobe is being affected and decision making is affected. And therefore, a person trying to hide the medication, we needed to re-educate. And so what we did is we re-educated, sent the person back to additional counseling, additional education classes, and also refer them back to our medical provider. Because what we found is that sometimes maybe the dose was not accurate. Maybe the individual maybe needed less dose or needed more. And so that conversation with the medical provider assists us in diversion. You can look at designating a housing area specifically for your program. Due to physical constraints, we haven't done that yet, but that is something that we are looking at in the future, to designate a specific housing area, so therefore all individuals that are on your program are housed together versus throughout your entire facility. So, but I found the education of our staff, letting them understand that individuals are going to make a mistake. They are going to try to, some are going to try to divert, but not all. And so we, individuals, for example, on Buke, we utilized the film. If they attempted to divert, and easily diversion could be as simple as the medication is moved from where the nurse has deposited it. That individual is then charged administratively. They are not removed from the program. They are charged administratively and then referred to additional education. If that continues, then what we do is, after I think 3 or 4 times of the individual trying to divert, we transfer them to a different medication, which is the pill. Well, we found that they don't like that. They'd rather have the film, so that reduce the amount of individuals trying to divert. But I think the biggest thing that you can do is have good training for your staff, to take it seriously, to have a very regimented process of how you do the medical dispensation that will allow you to understand. I've heard people say, well, we're going to handcuff them. I shouldn't have to handcuff someone to take medication. No, we're going to treat people in a humane manner. And what we do is, and listen, I have to be, my ego, I have to set it aside. And when someone comes to me and says, administrator, this is not working, originally I said, well, we're going to have them all stand up and put their hands at their side, and they're not going to move their hands, and we're going to dispense the medication. And one of the sergeants came to me and said, Warden, can I talk to you? I said, sure. He said, you know, some of them are actively withdrawing and they can't stand up. Can we sit them down and have them sit down with their hands on their lap? And I said, sure, that's not a problem. And we moved to that. And so it was a learned procedure in which we are learning as we go. And so then we realized that some people can't stand up because they're actively withdrawing. And so we sat them down. Then we moved to making them understand how they have to behave while they are in the medication dispensing line. And so it's all a process. And I think that education of our staff has led us, they're the first line of defense. They're going to know who is trying to divert. And also our medical team, they're the individuals that are in the line and on the forefront, and they let us know when they see something that is not right, and so that we address it. So we investigate right away. To answer the question about parole and probation, we made them part of our medication-assisted treatment program committee, have them send someone to represent that agency so that they're not surprised. I made the biggest mistake, and I'll tell you right now, so you learn from my mistakes. I forgot to call the drug the drug court judge and tell her that I'm starting this robust program here in the county jail, and she didn't know about it. And so the judge called me, and now I had to do a huge presentation on what we're doing with MAT in the correctional setting. And once they understood it, they were more than willing to say, well, you're not changing if the person is on a certain medication. No, Your Honor, we're not changing that medication. We're continuing the same medication that they were on the in the community. We're continuing the same medication. However, those that are not on medication and they want to participate, I'm going to allow them to participate. So that dialogue is very important. Getting out in front and talking to the different agencies and letting them know. I had a huge conversation with family, children and family, because there was a stigma there of either you get sober or I'm not going to give you your children. And that's terrible that a person has to make that decision between, do I want my children or do I detox and do not use any type of medication. And when we had the conversation, they proceeded to train their staff and try to eradicate the stigma that is associated with medication and substance use disorder. And so little by little, we're chipping away at it, but it requires a lot of communication. And you have to get out in the forefront and have that dialogue. Otherwise, it makes it very difficult.
If I could real quick, Shelley. Warden Taylor mentioned it, just to clearly lay it out though. Switching from tablets to sublingual, the price point is different. It costs a lot more money, but you definitely see less diversion with the the film for buprenorphine. And then the same with methadone. Methadone can come in wafers or it can come in liquid form. You see much less diversion in the liquid form because you can have that observed dosing and then the conversation with the nurse afterwards and make sure there's not really funny things going on with the voice or those types of things. The main thing in jail, and I've worked on jail, I've been on both sides, treatment and jail staff and all that, and I've spent a lot of time in jails and prisons. Diversion happens. Tramadol, Seroquel, and everything under the sun is running around those places. So diversion happens. We just have to get it under wraps, especially for these medications. And so the conversation after dosing and then separating med lines. And so I got asked a question, and there's good things and bad things. So the good thing is that you kind of have a more controlled environment and you can provide more protocols in that environment. But the bad thing is basically everybody knows that those individuals are coming to the second med line. So you're breaking HIPAA, you're breaking 42 CFR. Everybody knows they're getting these medications on the yard, meaning the prison facility, the yard. And so you do have that to kind of deal with. And so the more you can kind of keep that not secretive, but supportive to their anonymity, the better those things can go with their interaction with other offenders about their medication.
Thanks, Mike. And, you know, want to say thank you to everybody. This was a really great discussion. And I'm going to turn it back to Regina for closing remarks, and we'll wrap up. Thanks.
Great, thanks so much. Before I close, I want to see if Dr. Stern or Beth or Karen or Mike, if you have any, Warden Taylor, if you have any final remarks that you want to make, given we have about 3 minutes left, if you could keep it short, and then I will thank everyone for coming. Go ahead.
I'm impressed by Karen's program. I want to move out to New Jersey. I think you're doing so many, it's just so wonderful to see somebody in the custody position embracing this, understanding the public health value, taking bold steps, reasoning out the pros and the cons, from diversion to staffing education. I just think all the things you've talked about are great models, and it's wonderful to see. And I think in some ways recaps everything that I've said and some of the other speakers have.
I would only like to add that it's not as overwhelming as it seems. It is possible, you can do it. And as Warden Taylor said, like, you just start the project. So I've been on teams where we did 3 years of planning and we're still not started. And then I've had teams where they just made a phone call and said, Jimmy Smith's in the jail, can we dose him? And then we started the project that day. So I've seen projects start in a day and I've seen 3 years never start. So it's really just getting started and making that phone call and getting that person appropriate services. So it all starts there, in my opinion.
Michael is right. I think just starting your program, you can start small and build into it and make it as robust as you want to, but get started, do something. Because sooner or later, if you do not, legislation or litigation will make you start. And you don't want to do that. I wanted to get ahead of it and wanted to create my own program and not be let it be dictated by litigation or legislation. So therefore, specifically litigation, because sooner or later, someone is gonna come into your facility who has been on a program and would like to continue the program, and it's gonna sue you because you wanna detox them. And you're creating more harm to that individual by doing that. Rather, the gold standard is medication for this type of illness, and look at it as an illness. And you will not take away the diabetic medication that you give a diabetic. Look at it the same way. It's medication to hopefully treat someone and help them to be successful. So start your program. Thank you.
Thank you, Warden. Beth, did you have any final?
Just one, I think that anyone who's interested in doing this needs to find a champion. We have, lots of champions right here today. And from our work, we know that champions are willing to be champions in other places. So go find that champion, empty out their brain, use them to convince and grow champions in your own area, because that's how you can be successful, by bringing more people into your fold.
Thank you so much, everyone. This was a great conversation, and the conversation won't end here. As Beth said, we have people around the country who really want to help on this. For these projects, there is money available from the federal government. The state opioid response grants that every state has can be used for opioid treatment programs in corrections. Those, however, as Marc said, we need to focus on the cost savings that can result from these jail-based treatment programs in order to be successful at getting sustained funding that doesn't have to rely upon one-time grants as a regular part of correctional health care. So thank you again, everyone. We will have this posted shortly, and enjoy the rest of your day. Thank you.